Welcome to ATC, the Emergency Medicine Channel. Myself, Dr. Amal Johnson, first year PG, Emergency Medicine. Presenting the case of 73-year-old female who presented to ER with complaints of rashes along the right lower thoracic region since 2 days, along with pain around the right thoracic region. And after seeing the lesion, we had initially told the staff to wear masks and wear gloves, and we shifted the patient to an isolation room. And we also covered the area of the lesion. And on initial 10-second assessment, the patient was conscious oriented. She was obeying.
Take Herpes Zoster, not chickenpox. Herpes Zoster. What is the mode of spread?
So it can spread through droplet.
Reactive. But as such is not
Varicella and herpes. Both are zosters.
Yes. Yes.
One is acute phase and they come with sore throat, nasal congestion. Varicella is like sore throat, nasal congestion, upper URI symptoms, back pain. Then after that they develop all over the vision all over the body. Whereas herpes is the latent phase of that. That comes in some dermatomes.
Yes.
What is the mode of spread in both? Spread.
Droplets.
Acute phase is always droplets. It can even spread through the nasal cavity. All these things it can spread, like sneezing, coughing, touching,
skin contact.
skin contact. But whereas other one,
Reactivation
of the virus.
but it can also spread to other person.
Yes.
How it spreads?
Mainly if the patient is immunocompromised.
Skin contact.
Lesion.
There it is only by skin contact. The one is spreads through atmosphere. Okay. So you have to take care. Previously, it was known that it was told that there is no spread in herpes zoster. Now we know that it can even spread through skin, okay, through contact. So we have to be very careful. We have to wear gloves or mask, whatever it is.
So on initial assessment, the patient was conscious oriented. She was obeying commands. She was talking in full sentences. And on primary survey, there were areas pain. There was
Can chickenpox produce altered behavior?
Herpes zoster can produce altered behavior if patient has meningitis.
Sometimes patient can develop meningitis and encephalitis, small disease. It is very rare, but a severe form of chickenpox, that is hemorrhagic chickenpox, vesicles can be hemorrhagic. Sometimes this patient can develop toxicity. Sometimes patient can have multiple cranial nerve involvement, and even encephalitis, transverse myelitis. Everything is possible. So they also can develop neurological manifestations sometimes, but not very common.
And when breathing, the respiratory rate was 18 per minute. The saturation was 98% in movement. On auscultation, the air was bilaterally equal, and there was no presence of any added sounds. On circulation, the blood pressure was 140 per 80 millimeters of mercury, and heart rate was 88 beats per minute. And GCS was E4, V5, MCs. And exposure to the patient was febrile, and the patient GRBS was 180. And we took the sample history. She's a 74-year-old female.
She's a diabetic.
Yes. Known case of type 2 diabetes mellitus and hypertension.
So HbA1c is
7.
7. Is it controlled or non-controlled? Not controlled.
3 is taken. 7 is
What is the age of the patient?
73
years.
For that age, is it controlled or not?
Control.
There are targets in diabetes. Okay. In an elderly individual, geriatric patient, less than 7.5 is also accepted. We no need to reduce to a very low level, like less than 6.5. That is not required. Okay. Even 7.5 is also accepted, right? But only thing is, this type of problems can occur in patient. We can make to less than 7 or 6 point, it is well and good, but most of the patients may go to hypoglycemia. That's why in that type of patients, HbA1c is slightly kept higher.
She presented with complaints of rashes along the right lower thoracic region since last 2 days, and she also presented with pain along the right thoracic region, the lower thoracic region. It was almost around the T5 and she had presence of active rashes was present. there was no crusty. And there's no history of any itching or there's any over the rash or there's only no increase in the extent of the rash. There's no history of any tearing or ocular pain. There's no history of any blurring of vision or there's
Can this pain starts before? Can it start before the onset of skin lesion?
it can start.
That is a problem in emergency room. Many patients with the severe uncontrolled diabetes can come to emergency room with acute onset chest pain. Okay, we may miss the lesion if you don't examine properly, because sometimes you get only very minimal few lesions. Okay, ECG may be normal, so that confusion can arise in emergency room.
This patient had come to here 1 week back with complaints of right-sided chest pain, but that time there was no presence of any rashes. We took the ECG, ECG was normal. We took the cardiac enzymes also, cardiac enzymes was normal.
So the pain can even start much before the onset of skin lesion. Okay, and it will be a severe, intense pain, not like routine chest pain.
There is no history of any facial paralysis or there is no history of any ear pain or there is tinnitus that was not present. There was no presence of any.
Which are cranial nerves involved in herpes zoster?
The facial.
Trigeminal is the most common nerve which can be involved in this one. And what are the other type of presentation in trigeminal nerve? What are the different types of presentation?
So the patient can present as facial paralysis can also. No.
It is in seventh nerve.
Seventh,
If it is involved, facial paralysis can be there. Fifth cranial can be involved, which is the most common area.
Hutchinson side.
Is a common division. There are 3 divisions.
Yeah, V1.
Ophthalmic.
V1 will be.
Ophthalmicus.
Ophthalmicus is most common what we see, but we may not be seeing many cases because if V1 area, you may not notice at all sometimes. But V2 is the most common clinical presentation. Okay, what is Ramsay syndrome?
Ramsay syndrome is presence of lateral facial paralysis along with the presence of vesicles around the auricle.
Yes. So we have to examine all these things. Once you get a lesion in the thoracic area, you may think that okay, only that area it can come. A patient who is having already immunocompromised status like diabetes, he can present these lesions everywhere. Okay. What are the conditions you get? Multidermatomal herpes zoster.
In case of disseminated herpes zoster.
Say disseminated herpes.
Yes.
Where all you
It gets immunocompromised individuals, usually in patients taking chemotherapy or hematopoietic stem cell transplant patients.
Post-transplant
patients.
These are the
Retroviral HIV.
So these are the common conditions. Even diabetes is severely uncontrolled diabetes also a condition where you get multi-dermatome. So when you see only one dermatome, you should not stop it. You have to examine everywhere, especially eyes and ears, because that is one of the common presentations. And if the patient loses his vision, he will be responsible. We have to examine always. At least document that there is no pain anywhere else in the body.
So there is no history of any decreased altered sensorium or decreased sensorium or history of any fever, history of seizure. The patient had come to emergency room 1 week back, along with the complaints of right-sided chest pain. And the allergic history, the patient is allergic to local anesthetics.
Okay.
And the patient's last meal she had taken 30 minutes back. Patient has a past history of type 2 diabetes mellitus since last 20 years. And she is on, she also has a history of hypertension since last 10 years. And patient has a history of varicella zoster infection 50 years back.
Okay.
And
50 years, 50.
And drug history, patient is on metformin 500 milligram BD. And patient is also taking limiprid in the morning, 1 week. And patient is on amlodipine 5 mg, 1 OD.
Okay.
And after that, we move to the systemic examination. The patient chest, the airway is bilaterally equal, and the patient has no process of added sounds. and per abdomen, the patient abdomen was soft, not tender. And CNS examination and cranial examination, there was no significant abnormalities in the final examination. And motor, the power was 5/5 in all four limbs. Circular test was also negative. And we did the CVS, S1, S2 was normal. And
What is the common cardiac problems of diabetes? Common cardiac problems of diabetes. Coronary artery disease, everyone will get. I'm sorry, I'm not giving a chance for it. It is there everywhere. Other problems are, we are dealing that with in emergency room. We are dealing that in ICU.
Autonomic dysfunction.
Huh?
Autonomic dysfunction.
Autonomic dysfunction is one of the common problems. Okay, then one problem you never seen. That's why it's a cardiomyopathy. But what is the problem? Why we should worry about that? It's diastolic dysfunction. Diastolic dysfunction is the most important problem. We unnotice most of the time. And we give fluids and patient go to cardiac failure. Okay. Systolic dysfunction, everyone will notice. Coronary artery disease, everyone will notice. But diastolic dysfunction, most of the time we miss, and sometimes we give additional fluid and patient go to pulmonary disease. So that should be avoided if the patient is having diastolic dysfunction. Fluid restriction should be there from our side. We should not push more fluid to the patient. So we have to be very careful.
for this patient, we assessed the pain score. Pain score was 9 out of 10. Patient has severe pain. So we gave her a tablet, 3 gave her.
Okay. What is the type of pain he had?
He has neuropathy.
Neuralgic. What are the typical features of neuralgic?
There will be some radiation. It will be concentrated in one dermatome.
One dermatome. So what is it? The neuralgic pain, there is a typical feature. What is the typical feature? Huh? It's a shooting type of pain. It increases with bending forward, coughing, sneezing. It will be always intense. The pain will be intense, but it can suddenly shoot. The electrical activity can increase suddenly when you are coughing, sneezing, especially in thoracic area. So that also can happen. So if the patient is already having some cough or breathlessness, that can aggravate the problem.
So we gave her a tablet, pregabalin, Cetirizine. After that, the pain had subsided.
What type of respiratory problem this patient can have? What is the type of respiratory problem patient can have when they have severe thoracic lesions like this chicken pox or rib fractures or malignancy of ribs or muscle pain, trauma to chest? Lung is normal. Lung is normal, but they can have a lung problem. What is that? It's a common problem you see in oncology wards. Oncology wards, patient will be severely respiratory in distress and they may have hypoxemia. What is the reason for that?
Collapse.
Lungs are normal. Lungs are completely normal, but still you can have hypoxemia. What is it?
The chest wall expansion.
Chest wall expansion will be severely
Restricted.
because of pain.
Pain.
So this is a common problem in oncology problem, especially rib metastasis. Okay, they'll not be able to breathe. Okay, so in that case, the pain relieving is the best option than giving oxygen. You have to give oxygen. And most of the time, we'll end up in giving oxygen, but patient not approved. Okay, we have to be very careful. This patient can sometimes go to hypoxemia because he is not able to breathe. Pain will be severe.
So then we advised admission. The patient was like not healing. So
how do you manage this case?
So we had given her antivirals. Yes, antivirals we gave Valacate to her.
Okay.
1 gram we gave TAD for 7 days.
Okay.
And then we gave pregabalin. We had given 75 mg.
Okay.
We gave for 7 days.
Okay.
Along with that, we gave Randac. We gave 150 mg BD for 7 days.
Okay.
And
What is the role of steroids here?
steroids can reduce the
Yes or no? Tell me yes or no. Is there a role or not?
steroids.
There are role for steroids in certain conditions of herpes infection. varicella infection.
In acute neuritis place,
Neuralgic pain there is no role.
no
There is no role.
Encephalitis.
Can even
Encephalitis.
encephalitis initially I give. Okay. Bell's palsy. That's
Yes.
also viral
Viral
infection. There steroid has got a role, but not in this condition. This condition, if you give,
Only
pain
pain.
may decrease, but the lesion can expand sometimes. We have to be very careful. Okay. What advice you give to the patient on discharge? What is the advice you are going to give to the patient?
Isolation.
Reverse resolution.
uh,
Reverse resolution is use face mask, reverse isolation.
That's all he has already told you. What advice you give? That is for spreading. Okay, prevent spreading is all these things are required. And what is going to happen to this patient afterwards?
post can get it post.
Post-herpetic neuralgia will happen. In most of the patients, they will have severe pain for many days, maybe many years. Okay. In that type of patients, you may have to do some intervention, pain management. Otherwise, only pregabalin and carbapenem, all those things can help initially. But later, some patients will end up with continuous pain. It may last for long years, many years. So we have to be very careful when we are counseling the patient. The pain is not going to go off. Only the lesion is going to reduce. Pain will persist for many years sometimes. Okay. What? How much pregabalin was
Different
Yes.
video.
Okay. Anything else you want to tell?
So the post-herpetic neuralgia.
Post-herpetic.
Post-herpetic neuralgia usually occurs in that same dermatome where the initial infection had occurred. Usually 90 days after the occurrence of rashes.
Okay.
So for that, we usually give pain management. We give we get the different options. We can give carbapenem.
Okay.
Carbapenem we usually give 300 mg in first day. You can give 300 mg TAD for the second day, and 300 mg TAD for the third day. And we can give it increase as needed by 300 mg maximum to a dose of 600 mg TAD.
Is there a vaccine for chickenpox prevention?
Vaccine chickenpox usually we give it childhood. Childhood vaccination is there. Usually the vaccination is given at the age of
No, vaccination can be given at any age. Adult vaccination is advised in chickenpox. Any age you can give. There is no issue. But currently, nowadays, all children are getting chickenpox vaccination. They are not taken, they can take. Once you develop chickenpox, can you get chickenpox again?
there's a possibility.
It's a lifelong immunity. Chickenpox, once you develop, it is a lifelong immunity. But sometimes what can happen is herpes zoster can happen. Sometimes if your immunity is very low, it can be multidermal. So it can misdiagnose as chickenpox again. Once you develop chickenpox, it's always a very, very remote possibility to get a second infection. Okay. But if you have taken a vaccination, chickenpox can still come. What is the difference between chickenpox in a vaccinated patient and in a normal person?
Immunity is for 10 years after doing vaccination. There is no lifelong immunity for vaccination.
Lifelong immunity is there. Is there
But
vaccination?
all
But what is the difference? It is a
All
lifelong
strains.
immunity only.
different
Severity.
strains.
The severity will be very mild in vaccinated patient, but it will be severe in a unvaccinated person. That's all. But it gives quite lifelong immunity. If you develop chickenpox after vaccination, it will be very, very few lesions. That is the only advantage. That is hemorrhagic chickenpox.
So presence of that rashes along hemorrhage,
Blood
blood
there
stain.
will be bleeding inside the chickenpox lesions. That type of chickenpox is very dangerous. These patients can develop multi-organ dysfunction or complications are very common. Okay. But routine chickenpox complications are very, very rare. What are the common complications of chickenpox?
Because of disseminated herpes.
And the herpes or chickenpox, what are the common complications? Complications are routinely that produce skin lesion and subsides in 1 or 2 weeks.
Second is ocular complications.
I lesion can go. Okay.
Yes, then can be presence of retinal necrosis.
Okay.
In severe cases. Iridocyclitis.
Okay.
Presence of
Secondary infection.
Secondary.
What is the common area?
Lung infections,
Lung
yeah.
infection is the most common. Many chickenpox patients can develop secondary lung infection, bacterial infection. That is one complication. Second one is, can kidneys are involved? Can kidney involved in chickenpox?
If we give before giving antivirals, must
That is correct. If we are giving acyclovir, creatinine can increase if you don't give with fluids. That is correct. But can chickenpox type of lesions involve kidney, especially in children? What is
it's
the condition?
reyes.
Ray's syndrome is chickenpox with paracetamol intake. Fever is involved. What is the common problem if we have multiple skin infections to kidney, which bacteria will affect there, which can also involve the kidney, especially in children. Streptococcus.
Hepatitis.
So that can happen in some patients. Okay, so all sorts of complications can occur, but nowadays it is very rare because we have good antibiotics, we have good antivirals, supportive therapy is there. So these complications are rare nowadays, but if you don't treat it initially properly, then all these things can happen. And transverse myelitis can happen in some patients. GP syndrome can happen in some patients. Multiple cranial nerves can be involved in some patients. So all sorts of complications can occur in the post-viral period, post-viral infection period. A lot of complications can occur. But nowadays we are not seeing many things because of effective treatment. Anything else you want to add?